We'll also talk about clinical features, blood levels, presentation a little bit, radiology a little bit, and especially talk about differential diagnosis in the mediastinum. The anatomy is so interesting in the mediastinum because we have so many different structures like the heart, the vessels, we have nerves, lung, pleura, thymus, esophagus. All of these things move through the mediastinum. And so the possible tumors are very broad. It's important also to understand where we are. And we need to communicate this need to the surgeon to tell us superior mediastinum, posterior mediastinum, anterior, because the differential diagnosis is very different based on where we are. Nerve tumors much more common in the nerve tumors much more common in the posterior and superior mediastinum, very rare in the anterior mediastinum, for example. So where things are matters a great deal. So first, to talk a little bit about non-neoplastic disease. I know this is a cancer hospital, but we want to talk just a little bit about other things that can happen here. With the thymus normally sitting in the more superior mediastinum and covering portions of the great vessels and abutting both lungs, we can sometimes see neoplastic changes that involve any of these other structures. So imagine you see a thymus that looks like this. What do you think? What are these? Yeah, those are hyperplastic follicles. So differentiating follicular structures versus thymic hyperplasia is sometimes a problem because at low power, this looks like thymic hyperplasia, but when we see that these are true germinal centers, it says something's wrong here. And in fact, when we see germinal centers, the most common disorder is myasthenia. So this is a very common finding in patients with myasthenia gravis. True thymic hyperplasia is increased gland size, and this is low power. There are no follicles here. So true thymic hyperplasia may have associated follicular hyperplasia, but not always, as in this picture. And this is associated with some endocrine disorders that are unusual, not very common. Let's see. So patients who do have myasthenia gravis, as you see, most often have follicular hyperplasia, this lesion here, this process. Only 10% have a thymic tumor. So overall, that is rare in myasthenia gravis. And a large number, 25%, no pathology at all. On the other hand, if we do have a thymoma, a lot of those patients will have myasthenia gravis. So patients with myasthenia, low prevalence of thymoma. Patients with thymoma, high prevalence of myasthenia. Okay? It's a little different way to look at it. This is interesting to think about what causes the pathogenesis of myasthenia. As you know, it is due to antibodies directed at the acetylcholine receptor on the muscles. Okay? So how do people develop this? Well, it is thought that there are some myoid cells within the thymus that do have acetylcholine receptors, and that somehow those receptors are then presented to the T cells to proliferate and then respond, and then B cells peripherally will produce the anti-acetylcholine receptors. So the thymus is involved in the pathogenesis of myasthenia, but not always with recognizable surgical pathology. Okay, that's all we'll say about myasthenia for right now. Thymic neoplasms can include things that look like neoplasms, like this thymic cyst, which has peripheral thymic tissue and then cystic spaces, multiple cystic spaces. Many of these will have a recognizable epithelial lining, probably the corpuscles dilated in these situations. Besides thymic cysts, there are many other cystic lesions that occur in the mediastinum. And most of these are anterior, but as you can imagine, some of them, like the esophageal cysts or maybe bronchial cysts, may be mid or posterior posterior mediastinum in their presentation. We can have cysts related to the brachial cleft apparatus, thyroid, or parathyroid that involve the superior mediastinum. And then sometimes cysts can be associated with thymoma or even Hodgkin's disease. And these may be thymic cysts, like the one that we just saw. So all these cystic lesions will have slightly different lining. I won't go into the histology. You can find those very simply. Another benign tumor that sometimes will occur in the thymus is a very fatty infiltrated lobular lipoma. Again, very easy to recognize and not a diagnostic problem. This entity, sclerosing mediastinitis, is difficult. And other terms for this are idiopathic mediastinal fibrosis, but this is not the same as inflammatory myofibroblastic tumor, different from that. And it's not the same as the fibrous proliferation with sclerosing Hodgkin's disease or with sclerosis in a thymic cyst. Typically, we have a rather rich plasma cell infiltrate, and this disorder is one of these IgG4 sclerosing disease. Remember we talked about the Kuttner tumor in the submandibular gland? One of the IgG4 diseases. When we talk about the pancreas, we'll talk about autoimmune pancreatitis, which is one of these IgG4 diseases. Sclerosing cholangitis, another of this sort. And some mesenteric sclerosing diseases are also IgG4 diseases. So this is a group of diseases that is being unified, similarities between different organs, and the diagnostic criteria are beginning to be refined, but it's an important thing to recognize because usually steroids will respond to steroids. and that will relieve the problem. So being able to identify these can be very important to avoid major surgery. Okay, germ cell tumors. This is the most common germ cell tumor in mediastinum is benign teratoma. And oftentimes this will have this peripheral rim of thin calcification like an eggshell. Very thin rim of calcification. There are several other entities on the teratoma to be concerned with. Immature teratoma or teratoma with malignant elements. The type here is mostly to remind us to look for the various possibilities. I don't want you to memorize this is type 1, type 2, but I do want, when you see a teratoma, to recognize other germ cell tumor or other epithelial, or look for these other possibilities as you see one of these tumors. Beyond germ cell tumor, beyond the teratoma, of course, are the other germ cell tumors. Some of these we see with some frequency, and others like choriocarcinoma are extraordinarily rare. Seminoma, very easy to recognize the cells, clear cytoplasm, interspersed lymphocytes, usually males and involving the thymus, and these patients can do very well, particularly if they're younger, they don't have involvement of the superior vena cava, no lymphadenopathy or fever. So these would all be bad signs if they're over 35, involve other structures, lymph nodes, or fever. And the markers, PLAP will be positive, CD57 will be positive. Other markers could also be helpful. And of course, these would be keratin negative. Embryonal carcinoma, a little harder sometimes because many times this looks like adenocarcinoma. But if we see a younger male, middle-aged male, think of embryonal carcinoma as a possibility, especially if we can find any evidence of serum elevation of AFP or other markers to suggest germ cell origin. Yolk sac tumor. It's unusual for a yolk sac tumor to be a exclusively yolk sac tumor. Usually this is mixed with other elements and often implies a worse prognosis in the older male population where it presents, and also in children as well. Choriocarcinoma, as I said, it's very unusual. It's so unusual. This is the picture. I couldn't find one. I didn't want to take one from another site and cheat. So these patients will have elevated HCG, which may also be associated with other symptoms like gynecomastia or impotence that can be related to the hormone. Okay, so now we'll go on to thymoma. And as you may recall, I have some issues with the way the WHO classification works, so we'll talk about that. We still use it. It's a rather unusual terminology, A, B, and C, with different numbers, and then combination types. So it's a little odd. It doesn't fit with other classification schemes. And the other challenge with it is that there's not a lot of difference in outcome or behavior. So although there's different histology, it doesn't make much difference in outcome. So recognizing that, here are some of the other classifications that have been proposed. And it's still in discussion, even though this was 15 years, 16 years ago. I like Schuster and Moran's classification, which essentially says well-differentiated thymoma or thymic carcinoma, and then an atypical thymoma and thymic carcinoma. This is more on the pattern of neuroendocrine tumors, well-differentiated grade 1, well-differentiated grade 2, and grade 3 tumors. Some people still use this in some areas of the world, although I think most people use this criteria, the WHO, and the CAP checklist uses this as well. Well, what is the problem with this? First of all, I think we ask, why do we have classification scheme? What is it intended? Well, one is to be able to communicate to our clinical colleagues what is going to happen in terms of natural history. So that's the real importance, is to say, this is this tumor, it will behave this way. A classification scheme should also be reproducible and thus easy to transfer from this laboratory to laboratories in Cambodia, to laboratories in Thailand or the United States, so we all speak the same language. Ideally, it might also be connected to molecular events, pathogenesis, and histogenesis, and have some connection to make it memorable with other organ systems. So, do these classification systems accomplish this? Well, this is fairly reliable, except with some of these B types, a little bit more difficulty there. I don't know about this one. This is very reproducible here. Does it convey the biology? Well, let's look at the survival. So here's the survival curve using the WHO types. And if you look here, you see that these three, which are essentially these, all have very, very good prognostic outcomes, whereas type B, 3, and type C have different. So based on this kind of data, the Schuster and Moran classification very well communicates prognosis. And that's, to me, is the most important thing. So I'll use these interchangeably a little bit, but I wanted you to understand the outcome differences. Now, we also can look at outcome based on other factors like staging and histology combined. So these are fairly good prognostic groups. Encapsulated, minimally invasive, down to widely invasive, but completely excised. So this is still good prognosis. And you'll note here that this includes any histology, and this can include the atypical thymoma histology as well. The unfavorable groups are those with incomplete excision and widespread widely invasive unresectable, and widely invasive unresectable. So what's the common denominator here? Well, essentially, it's this. Good prognosis if it can be completely excised. Bad prognosis if it is incompletely excised or unresectable. So surgery, the kind of surgery that is amenable, is also a very strong predictor of behavior. That's underscored here as you look at multiple studies according to extent of resection, and you see complete resection, very good response, most all of these studies. Incomplete response, incomplete resection, much poorer overall response, 30 to 60 at the highest, from 16 or 9 at the lowest. So surgery, what kind of surgery can be done, is really the best predictor, independent of the microscope. So, having said all that, let's talk about the histologic types. So, Schuster and Moran well-differentiated thymic carcinoma or thymoma, type A, mostly spindle cells, fairly bland, very few lymphocytes, and occasionally has these meningioma-like whorls or little gland-like structures. Here's some more pictures. Almost a little bit of a trabecular pattern, usually encapsulated. More pictures. Here you see these little gland-like structures with a secretion, sieve-like glands here, spindle cells, no lymphocytes. Here's another pattern, rosette-like pattern that can also be seen in type A. Again, very few lymphocytes. So well-differentiated type AB, thymoma type AB, has both lymphocyte poor areas and lymphocyte rich areas. So this is a mixture of these two. This is fairly common. Here's another image, lymphocyte poor, lymphocyte rich. Sometimes these will be a little more intermixed, a little bit more difficult to differentiate these, but you should be able to readily see the spindle or epithelioid cells in this type. Okay, type B1, mostly lymphocytes. Looks a lot like lymphoma even. A lot of small blue cells. It's very hard to see the epithelium, especially at low power. So with this type of thymoma, we're often not thinking of epithelial tumor. We're thinking lymphoma, benign thymus, or something like that. So here is where the cytokeratin stains is very important to pull out the epithelial background. Type B2, a little bit more polygonal cells rather than spindle cells, moderate numbers of lymphocytes, but no atypia. So these are all the well-differentiated types that we've been talking about that on histology have good behavior and are usually localized. Now we start into the more problematic ones, the more aggressive ones. Type B3 has more rounded and polygonal cells, will have some fibrous septi, and a little bit more cytologic atypia, more nuclear pleomorphism. Here's a high power view. You see some larger cells, mostly rounded and polygonal, with interspersed lymphocytes. This is a little bit subtle to differentiate this from the B2s, but the nuclear atypia is really the key here. Sometimes you can have clear cell changes or more eosinophilic, almost squamoid appearing cells, but still with admixed lymphocytes. So there also has been some studies that have looked at patients with myasthenia and those without. So we said that about 30 to 40% of patients with thymoma will have myasthenia. So here's the story here. And this actually, I think, reinforces the fact that there's really not much difference in this survival if this is fully resected. If it's stage 3, it's usually fully resectable. Whereas stage 4, they may have a more poor prognosis. So a little separation here, but not much difference here. So I think it's largely resectability, but then whether or not they have myasthenia will make a difference. So if they don't have myasthenia, they may do a little poor if they have advanced disease. So here is the CAP checklist that we use. And as you see, this is the WHO classification. Now, if we have carcinoma, and we'll talk about this, you'll see that it can be a whole variety of histologic types. And we'll talk about neuroendocrine tumors very briefly. The same story, though, for neuroendocrine tumors here that we've used in the head and neck and in the GI tract. Of these thymic carcinomas, there are some differences. So lymphoepithelioma-like has different features in terms of prognosis than some of the other ones. So it is important to tell these apart.